Opioid prescribing and suicide risk in the United States. This is published in the American Journal of Psychiatry, volume 180, number 6. This is a full access articles published online. Abstract. Objective. The study estimates associations of regional change in opioid prescribing with total suicide deaths and suicide over deaths involving opioids. Methods. A panel analysis was performed with 2017 U.S. National IQVIA longitudinal prescription database data and National Center for Health Statistics mortality data aggregated into commuting zones, a number of 886, which together span the United States. Opioid prescription exposures, including opioid prescriptions per capita and percentages of patients with any opioid prescription, with high-dose prescriptions of less than 120 milligrams of morphine equivalents, with long-term prescriptions less than or equal to 60 consecutive days, and with prescriptions from 3 or more prescribers. Linear regression models were used with year and commuting zone fixed effects. Results. Suicide deaths were significantly positively associated with opioid prescriptions per capita, having any opioid prescription, having high-dose prescriptions, having long-term prescriptions, and having 3 or more opioid prescribers. Similar significant associations were observed between each of the 5 opioid prescription measures and suicide overdose deaths involving opioids. However, opioid prescriptions per capita, having any opioid prescription and having 3 or more opioid prescribers, were each negatively associated with unintentional opioid-related deaths in people in the 10 to 24 year and the 25 to 44 year age groups. Conclusions. In this retrospective study of the U.S. commuting zone level opioid prescriptions and mortality, regional decreases in opioid prescriptions were consistently associated with declines in total suicide deaths, including suicide overdose deaths involving opioids. For some opioid prescribing measures, negative associations were observed with unintentional overdose deaths involving opioids among younger people. Individual level inferences were limited by the ecological nature of the analysis. Reducing access to highly lethal suicide methods has been associated with substantial declines in suicide deaths because of their respiratory depression effects and narrow therapeutic windows. Opioids pose a greater risk than any other drug class of an intentional overdose prescribing to be lethal. And approximately 40% of overdose suicide deaths in the United States involves opioids. However, the relationship between opioid prescribing and suicide risk is complex. When people have their opioids tapered, they can become desperate if their pain becomes uncontrolled, or if they experience serious withdrawal symptoms, no matter why they received opioids. Long-term opioid exposure can also promote depression, which in turn increases the risk of suicide by any method. Given these complexities, uncertainty surrounds the connection between opioid prescribing and suicide risk, including opioid and non-opioid suicide deaths. It's not known whether certain opioid prescribing patterns, such as high-dose or long-term prescriptions, or having multiple opioid prescribers, are associated with particularly elevated suicide risk. A case-control study of veterans with chronic non-cancer pain found that opioid prescriptions had a significant dose-dependent relationship with risk of suicide, including suicide by overdose. However, a population-based cohort study of adults in Denmark may have been inadequately powered, did not reveal a significant association between long-term use of prescription opioids and risk of suicide. Alongside concerns that some opioid prescribing patterns may directly contribute to suicide risk in susceptible individuals, there are competing concerns that tapering or discontinuing opioids in adults with chronic pain could increase their risk of suicidal behavior. In a cohort study of patients with stable high-dose opioid prescriptions, tapering was associated with an increased risk of medically treated suicide attempts. A second cohort study found that stopping opioid therapy for chronic pain, especially after longer periods of opioid therapy, was significantly associated with a composite measure that included death by suicide or any overdose. Symptoms of depression may also emerge or worsen during tapering of long-term opioid therapy. In the previously mentioned study of veterans, however, the suicide rate among patients who discontinued prescribed opioids was similar to the rate among patients who received low-dose opioids and was lower than that among patients who received high-dose opioids. These findings are not consistent with the hypothesis that opioid discontinuation contributes to suicide risk. In efforts to reduce opioid overdose deaths in the United States, several policies have been implemented to restrain prescription of opioids and that have been coincided with a decline in opioid prescribing. Several, but not all, population-level studies have reported that lower opioid prescribing is correlated with lower overdose deaths involving prescription opioids. This research has generally focused on unintentional overdoses. One study from Ontario, Canada, however, reported that the regional rate of opioid prescriptions was not significantly related to concurrent opioid-related suicide deaths for men and was only weakly associated for women. Because regions vary in several factors that could contribute to suicide risk, the extent to which local opioid prescribing policies contribute to population-level suicide risk remains unclear. Given uncertainties surrounding opioid prescribing and suicide risk, we evaluated changes in regional opioid prescribing in relation to changes in overall suicide deaths, including suicide deaths involving opioids. We also examined opioid prescribing in relation to unintentional and undetermined opioid-related overdose deaths. We used fixed effects models in which geographic regions served as their own controls to evaluate regional changes in total suicide deaths and suicide deaths involving opioids in relation to changes in several measures of opioid prescribing. A greater understanding of these associations might help inform opioid prescription, surveillance, and clinical practice.